Guess I'll fit in.
Okay.
I wouldn't get-
Yeah.
Let's go ahead and open our meeting with a pledge to the flag. It's in the back corner. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
There's no red and blue in here. Forgive me, my voice is a little messed up. Do we have any public? No public, so I guess we have no public comment. Approval of the consent agenda? Any problems?
Nope, nothing serious.
Okay, somebody motion please.
I move that we approve the consent agenda as presented.
Second?
Moved and seconded, those in favor?
Aye.
Aye. December 2016 financial report, Cheryl.
It is not my report. Causing slowness. Sorry, am I away? Gosh. Okay. So, here is December. This was another really abnormally slow month in hospital patient counts for us. This month, we haven't had a month, well, actually a year ago, April, we had 345, but these 2 months are just really, really low. One positive thing I can say is that January has just been absolutely insanely busy in the hospital. And I am thinking we're gonna like really make up for at least one of those months in January, so time will tell. Ancillary services were also, kind of down a bit, but naturally they're gonna follow the hospital patient counts. So lab and radiology were down a bit. Rehab is up 17% year over year. So that number right there is awesome. The clinics are also up at just the 3%, so that's not too bad. And then we are looking at our monthly revenue. Our current month is sort of the orange color here. So you can see that we also had another slow month revenue-wise based on those patient counts. Our revenue for the month was 2.4 million. It's brought our monthly average down to 2.5 million, so not really any surprises here. Collections on AR are down here. In blue is the current year. The main driver behind this, besides low billing because of low patient counts, was that our cost report was put on hold for most of December because we didn't file our cost report on time. Now, they really only filed the cost report about a week late, but once you get put on hold with Medicare, it takes you, 2-3 weeks to get off of hold. So the money that we should have collected here came in January. We are off hold with Medicare. We got a $500,000 payment from them fairly early in January. So that's good. So January, our number is $1.9 million, which you can see from our averages is a very good collection month. So
Cheryl, is that January month closed out though?
the only information I can tell you for January really is cash, because that, we count that daily. We know what we've got.
Oh.
I don't know what our revenue is. That doesn't usually close until about the 10th. I couldn't get patient counts mainly because Sheila's on vacation and she hasn't done them yet. So I probably will have those early next week.
Oh.
So yeah, that's kind of the only thing I can see in January with any real accuracy. This is our current days in AR. It went up to 92 this month. Again, because of the Medicare hold. So I imagine it'll come back down into the 80s next month, but it still is way too high. Go.
writer
Can
error.
you-
I guess so.
Alrighty, days cash on hand is blue. We've been low this year, not surprising, so this number right here, days cash is 126 days. Now, I did do a bond advance in January of $2.5 million, so if we would have got that money in December, because we had paid out all our expenses in December, we would be at 166 days, which is way more right about here where we are comfortable and have been for quite a long time. So, because remember again, we're only doing the bond draws every other month, because they cost like $1,500, $1,800 every time you do one, because you have to have the inspector come out and make sure everything's correct, and they go through it very carefully. So, we're doing it every month, so we're gonna have an up-down with you know, a lot of these things until this project is over. So, God, what is wrong with me? Okay. All right, so this is our profit and loss statement. Next month, I'm gonna make sure to go ahead and put Wellness Center's budget in. For this month, what I did was to add Wellness Center's actual to our budget so we could see what are our budget variances without any effect of Wellness Center, okay? So based on what we all actually thought, you know, was gonna happen last year. We are behind year-to-date revenue-wise $969,000. Now, 2 months ago, in October, we were only behind by $200,000, excluding Wellness Center. So this number has grown that much in just the 2 months, so that's painful. Our wages and our employee benefits are under budget. What I find when I look at the detail is that this number is kind of a trade for this number. $250,000 of materials and services is amounts we are over budget for temp labor. So we're using more temp labor than we thought we were going to use, and it is expensive. But when you don't have, you know, so we have temp labor, but we don't have these regular employees. And then the benefit number is going to kind of wash out by the end of the year because our health insurance has gone way up. So we're under budget now, but we'll be about net even, I think, by the end of the year. Another thing that really hit us this month was, part of materials and services was, you probably noticed in the detailed P&L, KCC sent us a bill, and I did not realize it was going to come in quite that form, so I had to record $70,000 worth of expenses this month. I amortized the rest of it over the rest of the year, the months that I could, but I had to kind of suck it up and put that in. So, so for this month, we lost.
Do we owe them any more, or is that the final?
That is it,
Okay.
yeah.
Is that it for permanent?
Well-
Are we through paying KCC in total?
Now, they will be asking again,
Oh, yeah,
but
okay.
we do not, that ends our obligation. Okay?
And that was at approximately somewhere in the neighborhood of an $85,000 request they asked for, what, 3 years ago?
It was,
Somewhere in that.
it was $75,000 a year,
Here.
and it was for 3 years. And we paid them initial, they hired somebody, and we paid them as they were asking us. And then they didn't do
They
anything.
bill us.
And when they finally, they got a new chief financial officer, and then they lost that new chief financial officer, and they got another one, and that's the one that sent us the bill. And that's why we just got it.
No, they're not asking
I beg your pardon?
for it. People know they're not asking for it.
Exactly.
But now, Charlie, do you mind a question here? Are we offering any of the nursing classes here on our hourly campus, or is it all?
It's here.
It is
So
here.
Well, you have to understand, there's a couple components of the class. There is the didactic in the classroom setting, and then there is the hands-on touching and practicing with patients. Because of our volume of patients, and they've had a little trouble organizing their clinical component. Who's gonna oversee them, how that's gonna work. Most of the classroom is, most of the use of our space here is the classroom purpose. So they sit in here and watch the class being taught in Klamath Falls.
So this is the first year
And,
program.
but they're here on our campus, they're not on the ILC campus.
They're on both.
No, they're right
They're
here.
on
They're both. No, they're not on the ILC campus at
No.
all.
Okay.
So they are, what's called the first year RN student. Since this is their first year, we only have one cohort of students. So they are here Monday and Tuesday afternoons, and they do all of it over the TV screens and
So it's
lecture and
interactive.
answer. It's interactive, it's down in the classroom, and then on Wednesdays and Thursdays, their clinicals are in Klamath Falls. So they go to Klamath Falls, and in the morning, from like 6 in the morning till noon, they do clinical, and then from 1 to 3, they just stay there for their lecture.
But we don't have an instructor physically over here.
No. Right
It's
now, we
all
don't.
over.
And then next year, there's 3 students. They will go to their second year, which is their last year, and they'll admit more into the first year. So next year, we will have students 4 days a week, is the anticipated. And then Fridays are held open as their extra lab day, say they need more work on a subject. We've already had that. We happen to have all of the equipment the girls needed to practice, so we just, my nurse's aide instructor worked with them to practice on Friday.
How many attendees are we guaranteed, Charlie?
From Lake County.
Yeah.
That's 50% of the allowable age of students that they can teach. Now, part of the reason why the process has been not easy to do, first year, they could only take, the Board of Nursing required that it had to be LPN to RN. That was the first transition year. So just those LPNs that had finished from the KCC program could be in that class.
And there was only one that took that class. When?
So once that finished, then they could start with the first class of starting, once they've met all their criteria to get into nursing school. That's the first cohort that's teaching, is being taught now.
And we had 3 apply and 3 qualified and 3 were accepted.
And so over time, it's now going to build. And then our goal is if we have enough, students need to have good enough experience where they have enough people they can practice on, either as practicing or teaching experiences in the different kinds of cases that they can work on. And they have to have an instructor here. And that hasn't quite all been sorted to. We're working on it. But, so that's kind of where it's at. Does that answer?
I think, yes, thank you.
Okay, so we lost 175,000, has a lot to do with us being under budget for that. Questions on income statement? Balance sheet. Okay, again, what we're seeing here is on one month, we're gonna be spending cash on construction, so our cash is gonna go down and our assets are gonna go up. The following month, we're gonna do a draw on the bond, and our cash will go up and our debt will go up. So for this month, really the only noteworthy thing that happened to our balance sheet was that we spent down our cash and our assets went up here. But honestly, nothing else happened. The Wellness Center, we've been looking at as kind of a standalone, so for the month, they seem to settle down around 20, 30,000, sorry about that. Net a month for a department margin. They are still looking to hire some people, but we don't expect any radical changes from their spending levels current. Goose Lake Medical, any questions on Lakeview or District?
The wellness center lumped in with our Medicare
Yes.
reimbursement.
Oh,
Medicare, it'll be as it's viewed as a part of a clinic of the hospital, it will be.
I know.
Because the preponderance of the patients are Medicaid recipients, it will be impacted by, we file our Medicare cost report, and then Medicaid looks at that and finds our costs. So we will get our cost-based reimbursement for Medicaid, including that clinic, any of our clinics, or any of our
So boil it down to 101%.
Okay, so,
And just so that you know, the incentive dollars that come out of the CCO, where we get paid additional amounts, you may recall, we've talked about how there have been, because our CCO has worked pretty well, and we've done pretty good at gathering, caring for our patients, and then meeting the metrics, you recall? Those dollars that we receive are not included in our cost report. So that's, that does not go against our, the revenue toward that. So it's over and above. So it's a little bit of an incentive.
so next, Joey Randall, our new accountant, who's doing awesome work, is working on the budget and has completed the calendar for the next budget year for us. And I don't know if you want to say a few words about that?
Sure.
All right.
There's not much to say about it. Just some important dates. The next major date is March 2nd, which is the next board meeting. We'll have the budget assumptions ready for you. And then the actual budget meeting will be May 24th. And then the next board day will be June 1st. We'll hopefully get the approved budget done by then. And approved.
So the board needs to approve this budget back in second.
Yes.
The calendar.
The
Calendar, rather, excuse me.
So we'll get the completed draft May 15th for a meeting on May 24th. So we'll have 9 days to review everything that's presented to us.
Yes, if all goes as planned.
It will.
Because that's one of the things that's been, just for your information, kind of a little bugaboo in the past is not getting it quickly enough for us or the budget committee to digest and review.
That's why I'm here.
Good.
Help out with that.
Okay,
We should get it done by the 15th. We're already starting to work on it. So.
thank you.
Do you need a motion on that? I will approve that we, I will move that we approve the budget calendar as presented.
And I'll second that.
Second, those in favor?
Aye.
Aye.
Oh, surplus property.
Yeah, big item.
We did.
I understand, but every time we designate something,
Something like that, yeah.
so what happened is the federal government determined that those were illegal to have in a hospital. We had to remove them on relatively short notice. It's not a big item, but there still is value to them, so
I move we declare them surplus property.
thank you. Our plan is to give them
Is there
to
a second?
Second.
give them
Those
to
in favor?
You now have the floor, Charlie.
Excuse me for interrupting.
I think that's approved.
Thank you.
Where did they go?
Yeah.
Our Bat Humane Society. They cannot be used on humans, so we would either
Dogs
give
and
them.
cats go.
Humane Society.
I'm not sure that we
So they're
want to
going
send
to
them
the
to visit a foreign country. If they're not, they're fine for animals. They were fine the day before.
Yeah.
Thank you.
Medical services financial report.
Okay, we'll start with Lakeview Gardens. Their patient count was 602 for the month. Their average for the year is 650, so they're slowing down a little bit in December. But we are still 550 patient days for the year ahead of where we were last year at this time. That's good.
We had 5 deaths from Thanksgiving. Six
Wow.
deaths. So we had a lot of, that's a big thing.
Yeah. Revenue for the month was $177,000. Our average has been running closer to 190, so that number is a bit low, but not unexpected with patient days. Our profit and loss for the month, again, as in the hospital, for Lakeview Gardens, their revenue was down a bit, and then they had $54,000 worth of CNA labor. So that hurt, and we lost $44,000 for the month, which brings us to a year-to-date loss of $3,000, which is still $106,000 better than we were doing last year at this time. And the other bit of good news is Melinda has 10 students for the next CNA class. So that's pretty good. Balance sheet, I really, nothing going on here. The debt went up a touch, but the cash is up too, so the patient AR is down based on billing, so really no significant changes. Questions on Lakeview Gardens? Okay. Goose Lake Medical, they had net revenue for the month of, or gross charges for the month of $57,000. It's about average for this year. It's still not quite where it needs to be.
So the orange is 2017?
Yeah, sorry. The orange is the current year. Yeah,
Yeah.
this, right, it looks better on the computer
You
screen.
have two 2016s there, that's why.
Well, isn't that's slick.
Just wondering.
I have no idea. I'm so sorry. 14, 15, 16, there's 4 bars. Maybe it's 13, 14, 15, and 16. There must,
Isn't it 14, 15, 16, 17?
17.
Fiscal year 2017.
Yeah.
But the orange is showing up as, but
Yeah.
what's the
Yeah, I don't know.
first
This
2000?
is the number, 2000.
this is the current year, I'm sure of that.
Okay.
This is the last 3 years before that.
But it's the fiscal year
I'll
you're
fix
showing.
my, yes, it's the fiscal year we're showing.
So that's,
And this would be last year, you're right. So this should say 17. So 14, 15, 16, and that should be 17.
Right.
So we'll fix that on our worksheet. I've never noticed that before. I
maybe
don't know.
HR.
We have not been doing that every month, I'm sure. I'm pretty sure. All right, so this is 17. I'm sure of that. $57,000. All right. For the month, what happened to my?
You went
Did I
backwards.
go back?
You went backwards.
Oh, I'm backwards. Oh, I see.
There you
Oh,
go.
yes.
Wow,
Is
that's
that-
your first name.
Me?
So glad there's someone else.
Okay, the loss for the month of December was $11,000. The loss for the year is $43,000. Last year at this time, it was a loss of $124,000. We are still short of providers down there. They also are on hold with Medicare because their cost report is not done with Whipley. So we're charging, but we're really not taking in any money. So, there's nothing I can do about that till Whipley wraps it up. I know they're working on it, but that's all I can tell you. And our last entity that we are reporting on is our medical supply, our DME company. For the month of December, their sales were at 38. In January, their sales are all the way up to 8,000, based on oxygen sales that they've done. They had 11 patients. They are adding almost 6 more in the last few weeks. I expect that to continue. I'm not sure at what rate or where the upper limit might be, but they are starting to rapidly gain ground. Their loss was 12,000. Their year-to-date loss is 50,000. We had budgeted 33, so we have a bigger loss than we planned on, but.
How are you gaining ground when you're 2,500 more
We're gaining
in
ground
loss
in the sales
than you were the
department.
month before?
We're gaining sales, we're gaining revenue. We're selling oxygen patients, which have very little cost associated with And these costs should not grow
And they're,
in tandem with revenue.
but they are in debt to the hospital. How much?
$166,000,
And how are they paying that back?
because they're,
I mean, are they paying that back by the month? Are they?
well, they're not paying it back now because they're not generating a profit or
We
as
lost 13,000 last month.
Yeah.
So they will need to become profitable and generate excess cash and start paying back the district.
One of the things we want to keep in mind is that we knew it would take at least 6 months before we could become certified by Medicare and then therefore bill Medicare patients. We got that approval in November, I believe it was. So that changes what we can do.
And
Right,
we've gone
and that's where much of the,
from 0 to 17 oxygen clients in 2 months. And it kind of does, I mean, it goes by word of mouth, so the more people are getting, and they do get really excellent service. It's for sure that the hospital will call Michael at home on Sunday night and say, we want to send this lady home, but she needs oxygen, can you come and set her up? And he goes and he does it.
We got a thank you card, and I think it was because of the,
Yeah, that's what it was. He is on call 24/7, he doesn't ever hesitate to go. And that's how we're gonna build business.
And we knew that when we started that, but let's hope that in a year we see some profit here.
I think you've been very clear that you'd give us a year to maybe 2 years in this adventure. If we don't do well, we'll reassess it. So we, and
And we
everyone.
certainly need to see a trend within a year.
Oh, my goodness, yes. And I think it is absolutely well understood by all parties in this.
is that everything you have, Cheryl?
Yes.
Grant update, Christie Alvarez.
Before we do that,
Oh, wait.
Leafy Gardens.
Oh,
Did I skip the gardens?
Yeah, you
Skip
sure
the
did.
gardens.
That's an update.
Well, I'm
We
sorry.
don't need that yet.
Oh, so I think she just got
I was just getting it ready after
Just because I
Charlie.
can't see.
I just want to give everybody a quick update. I've been in and out of the buildings quite a bit here in the last month. And things are moving along in building A, it would be, which is the building closest to us, this building. And the kitchen cabinets are in, all the surfaces are in, meaning the kitchen counters, bathroom counters, laundry room counters. They are working on some of the electrical. We had quite a lengthy go-around for the acoustical panels in the dining room ceiling, and that has been adjusted now, and it comes in right close to budget for that. And we continue to work with the lighting. There was a change in our light fixtures a couple of times because the state got involved, because there has to be, because it's a home, the hallway lights have to have so much lumen that they put out, so that's been changed. And the fixtures, I'm not happy with, so we're working with that. And the fireplace on the inside has been rocked, and it looks gorgeous. And every time I'm in there, the workers are just working. They're working, all the bathrooms are tiled, and I just approved the decorative strip that goes on the top of the tiling, and that, what they proposed, what they originally did, the tiler was not acceptable, so now that's being adjusted. And they look great. I know, let's see, the vanity was installed, they were getting ready to put in sinks everywhere, the toilets were being put in by the plumber. So it's moving right along. They anticipate to be completely finished with building A by February 28th. Now, we can't occupy it till we do have our letter of occupancy, and both homes A and B are coming under that license. So there is building construction going on in every home. So when whatever is finished in C, or in A, they move to B. When they're finished in B, they go to C. And if you drive by, siding is being put up on building C, which is the assisted living. And they do have a local contractor doing that. So it's all moving along, and they did get the roof on already on building C. So you can see the colors of the buildings too, and they'll all have the same rock work and stuff. So the other thing I wanted to bring up, and I think they're trying to get it up, is the names of the 3 homes in the gardens. So I have, can you scroll down to the very bottom? So we run this through several different names. One name we had in the mix is a noxious weed in this county, so we had to take that out. Another one, just little minor.
Just name it noxious weed.
Yeah, we thought the farmers and the ranchers, that'd make them really happy to have that. And then the other in this county Rosemary Home, for instance, is an annual here, not a perennial. So we decided to toss that out, So we tried to come up something that we could actually grow here, would come back every year. So Lily Home is your assisted living, and that's the very bottom one, and that comes, we're looking for the oranges and the pinks and the yellows, and those do wonderful. You can buy them in a variety of colors, and they'll come back every year. So that'll kind of be the main focus. There won't be lilies next to the other 2 homes. So it'll kind of help us with the gardens and, distinguishing homes. And then in the middle home, which will be Building B, and that is long-term care. So remember, Building C is closest to 9th Street. There'll be the city property, which will be a parked area. And then there will be Building B. So we came up with wild plums, since we know that wild plums grow around here all over the place. So that's Building B. And then to the top, we came up with lilac or home. So again, there's a variety of colors and things like that.
So Melinda, are you going to landscape around the theme of each home like that?
You
And
have
we did-
wild plums in there?
Huh?
More than one wild plum?
I don't know that. We just came up with a name. We haven't actually seen, Charlie can go into more the landscape architect, but we did just talk to Mike Crennan at the last construction meeting, which was just Thursday, and they are, oh yeah, we're coming in, spring's not that far away, we better get our plan together.
Yeah.
So we'll see a architect, exterior plan
Well,
for.
that'll help the deer and birds, don't it?
So, well, and then I think Christie will go more into the grant, and they're working on those butterfly and bees and, pollination and things like that. So that's kind of where we're going. And questions now?
I noticed that you didn't have front doors exposed. Are there front doors on there now or
No, that will be one of the last things they do. One of the very last things they do is put in the flooring. And then the front door, they told me, would be one of the last things they do. Now, the bad news is, we were just told Thursday at our construction meeting, they don't anticipate being finished with all 3 buildings till right at Memorial Week.
Oh, Memorial, not 1st of May, now end of May.
End of May. They're having a heck of a time with electricians. And I can see that in the first building. The switches aren't in, the dimmers aren't in. I have some rooms with light fixtures, no light fixtures in hallways, things like that there is an issue with electrician.
So where does that push back occupancy date?
Well, I'm looking that if, say, we get it Memorial Weekend, we've got to go in and clean, and we've got to go in and stock. Our committee meets every other week in deciding, we have the small kitchenwares list done, we've got our bids done, furniture, which place is having which types of furniture for the clients they have. And that we have to order, we've got to give ourselves at least 12 weeks for that furniture to get ordered prior to us needing it, because it takes 12 weeks to build it and get it here. So we're staging all of that and then storing it until we can get it in. So I would look to say within, Charlie would have to tell us on getting the inspections for occupancy is after they give us the keys, I would assume.
What'll happen is once we get the occupancy permit, that'll have all the approvals. So as quickly as we can after that date. And it's still a little fluid because they are having trouble getting their subs to finish the work.
And to have their work the quality that we want.
So,
The work be the quality we want.
Charlie, if you run this late, is there some liability that we should be reimbursed for?
I don't have an answer on that. They just told us on Thursday that of this next delay. It's very frustrating.
Yeah. Because it does cost us that we have to use for the other spaces and so on. Well, thank you.
So, you know, if you have any concerns about the names we've selected, let me know. This is the first time I've brought it out in the open, other than just small groups of talking and trying to get opinions. So we do have our first Seroptimus group is going in on the 28th of February.
Yep.
Larry's in charge of the tours, and then in the middle of March, we have the Rotary going in. So after the 1st of March, I can do more tours into the first building, which the other ones are going to be exactly alike. And so what I plan to do for open house, which would look to be the first week of June or second week of June, I'm guessing. We don't have a date yet, but we'll need to think about an open house. And what I would like to do is have Building C, which is assisted living, and a long-term care home open as part of the tour, not open all three. Mostly because there will be different furniture for though each type of home, because what we need to sit in for long-term care is really not what we need, living room furniture for in assisted living. So we're gearing that.
Does the assisted living have some in-room, like a microwave?
No,
refrigerator?
no. We didn't with the small home. We would have had to make, first of all, a bigger home. And with the small home concept, they have access to the kitchen within a short few steps away. And we were accommodating in our refrigerators, we have 2 refrigerator freezers, that they'll be able to store their own food, and a microwave accessible 24/7. They also, and Larry will go into this here, is we are putting together what's called a service plan. Each client that goes into assisted living will have to have a service plan, and it's saying what their needs will be. Roughly right now, it's about a 15-page assessment. And we even have to assess their ability to independently use a microwave. We have to do within 24 hours of admission, we have to do an evacuation drill with them to see how long it takes them to get from their room to the outside in case of an emergency. And that, he'll go into how we're working on the financial part now.
Melinda, do they have the assisted tracking in the assisted living facility?
Yes,
or
they
just
do.
All three?
Which changes, I will tell you, very, very, very few assisted livings have, if you need a 2-person lift, you go to another facility, you don't stay with assisted living. We are planning that they can stay if we can meet all their needs in assisted living there, and that includes lifts, which means that I have to have 2 people 24/7 to be able to assist with the lift. You cannot have just one person using the lift. One staff member is not safe.
So Melinda and I, we traveled to Lapine and Bend, and I called around to Medford and Klamath to kind of get a base rate of what the assisted livings go for in our area. And I've been working with Cheryl, had a couple meetings with her to figure that out. And they normally come in around $3,400 to $3,600 for the base rate. And then on top of that, they have a tiered system, which is based on points. And those points are equivalent to minutes to the care that's directed towards that activity. So if they require 3 or ask for 3 showers a week, then they get 20 points. And then,
Or if they need assistance with those 3 showers a week, that makes their points go up.
and that's just an example, if they need help feeding, then those points go up. We haven't decided how many points are going to be in each tier. But the service plan that we got from a home in Lapine, they go from 20 to 41 for the first tier, 20 to 40, and then 41 to 65 for the second tier, 65 to 90 for the third tier, and anything over 100 is the highest level of care.
And we will develop a cap, so that if your points exceed this, that means that your care needs are higher, and you will need to go to a higher level of care building.
Which means they, in our case, they might have to go into long-term care.
Correct.
Yes.
It's saying that, you know, if I need all my meds given to me, and I need wound care, and I need this care, and I need that care, you're really truly needing a nursing home care. And so with more licensed nursing and more CNA care. So that higher level of care, they'll have to be discharged to the higher level of care.
How often do you adjust the point system? of the
Quarterly.
patient?
It's required by regulation to be evaluated every quarter. There's patient care conferences every quarter. And those new assessments have to be done by an RN. And then they're reviewed at that quarterly meeting. And so you might be watching, it doesn't mean that if somebody, gosh, one place we even looked at, if they went to a doctor's office and had 1 or 2 new medications given, they put them on a monitoring system and they raised their rates that day. So we're trying to, you know, do a common sense balance. But those points all equate to time it takes to do that.
So Melinda and Larry, in our situation, will you separate levels of care in the 2 long-term care facilities?
We're going,
We don't really want to.
Okay.
We want to make them
Do
as
a
equal
mix.
as possible.
Okay.
Because if we have all of our 2-person transfers in building B, it would require a lot more it would have a higher acuity and would need to staff more for that building and then less for building A.
but in building, say, building A, there is no acuity system built into the state regs. You just have to say you have to meet the needs, but if I have 12 residents, that means 3 CNAs in building A, and maybe they're mild as minimum assist to independent, but I have 12 patients that are 2-person assists in building the second house. 3 people is what's required, but let me tell you, they're gonna need 5 people to care for 12 people that are all maximum assist. So you wanna balance out your residents, so you have that mix of independent assist and dependent.
Do we have a waiting list for folks to,
It's illegal to call it a waiting list.
okay, you got a sign-up list?
We have an admission list currently going. Yes, I do.
I've been sending people down, and I'm disappointed that it's been put off, because I've been selling it to
We've
people.
been telling them that. We've been telling them, and then our brochures will be ready and all of that. We keep the potential resident's name, their contact person, and it may be themselves, and their phone number, so that we can get a hold of them as this progresses with the finances and, you know, tours and things like that.
And is that for both long-term care and assisted living?
No, that's just assisted living.
That's just assisted.
And your policy in the existing system is not to move people around. If one of your buildings gets out of balance because of the census is changing, can you move somebody from one to the next?
You better have a good darn reason and prove it to the state.
I mean, if for your benefit, you might be able to balance your staff better, that's what I think.
True, but there's.
But if you have
Why
5
that-
people die in one and none in the other, what do you do?
I'm gonna
Do
be
you move
admitting
somebody?
it, I'm gonna be admitting it given that it's happened, passing away. Which is basically what we do now. Right now, we have to consider where's the space available, which hallway, which room, are they having a roommate, not a roommate? Okay, who watches TV, who likes this programming? We've had the sci-fi to the Christian channel, and let me tell you, that doesn't work in the same room. You know, who snores at night, who doesn't snore at night?
But that's gonna be helpful in the new facility because
Right.
you only have 1 person.
Right,
That'll make that
that, I
much
mean,
easier for
there's,
you.
it's a heck of a lot of work right now trying
Yeah.
to find placement. But that's what we do to kind of balance it out.
Sure.
Where's it noisiest? We have, a couple clients that are extremely noisy. Okay, well, this person's really hard of hearing, they'd probably do better over here. And so
What'd you
we'll
say?
this one. So, I mean, it just is a lot to find that, but we'll do that. We'll be weighing and where's most of our dependent, where's this person going to fit in the list? And I look to see it being a little easier than
And in terms of furnishing, kind of resident bring some of their own
that. In
chairs
assisted
or
living,
hang things up on the wall.
in assisted living, their bedrooms will not be furnished. They will have to bring their own furnishings for their room. Whatever they have at home, whatever they want to, I had one of my employees' mother move into an assisted living, and she said, none of this is going, take me to the furniture store. And she bought all new to furnish her new digs.
Good for her.
So we will be furnishing assisted living, the den, the hearth room, and the dining room. And then and in any of the homes, we want to personalize that room like we do now. They have a little more space in the new room, so if they have family pictures, they want to move one wall, all family pictures, they can do that. We don't care, as long as, in the furnishings, we like them to bring their favorite chair. As long as the springs aren't showing through and things like that, and it has to be a washable surface. Now, we've had some show up with their favorite chair, and literally the springs were already through. So, long-term care, we will supply, of course, their bed, their nightstand, their dresser, and all of the rooms already put in is their medication cabinet. So those are, or at least in the one building, those are already installed. So look for, now if you guys want a tour before the end of February, I'm happy to do that. It will either need to be on the workers' lunchtime or after 3:30 in the afternoon. So anytime you guys, I just need 24 hours to let Jim, the boss over there, know. And so
I'm good for going through with Rotary.
And Muse rocked us.
We're
So
hoping
do you
for
want
it.
to?
I was through last week.
Okay.
By the way, Charlie, you were complimented on what you did with Robbins. I don't know what you did.
Laura, do
Just describe us a little bit about what
do
we're
we
doing.
have, they have good lights up where hard hats?
No,
No,
I think, did they want shoe covers?
We'll just be furnishing shoe coverings. But just to protect our surfaces, but.
And that's why we had to schedule for the certain times that we did, and to make sure that it was okay from a liability standpoint. So that's why we.
No vests or no hard hats.
I was hoping everybody had to wear a hard hat, but.
you
Makes
may
it
not
kind
have
of,
enough.
pardon me?
No, we had a large group and we didn't have enough to do it, so that's why we kind of plan our tours, and I've done some tours for staff and for department heads that needed to pay attention to, housekeeping, kitchen, those kind of stuff. And so we've had to work around construction crews.
Well, thank you, Melinda.
I have one more thing I'd like to say.
Okay.
I want to let you guys know that I finished my training program and I submitted my paperwork to the state last week. So I'm waiting to hear back so I can take my test, hopefully next week.
All right.
Good.
We won't tell you the date, we'll just tell you it's passing score at
Pretty long-term
the end. No stress, we don't want anybody stressing.
All right, we will move on to Christie this time.
This time. So for the grant updates, I want you guys to know what's going on. For so many of these, I have to list our board members' names and contact information, and it would just be a terrible thing if one of these foundations should call and you have no idea what's going on. So this is what's going on. First, we just found out last week that we got a $4,000 grant from Immunize Oregon that is going to let us start offering vaccines to kids. In order to be compliant with the Vaccines for Children program and the CDC, you have to very, very closely monitor the temperature where you're storing your vaccines, because if it fluctuates, then the vaccines are no good. So this grant is gonna allow us to buy thermometers that are gonna keep really close track of everything. It'll send updates to computers or to smartphones so that if something should happen, the power should die and the generator should die, we'll know right away and we can take care of the situation. So we will be able to purchase those, I think by June. Is that what I told you? By June, we have to make those purchases and up and running and good to go. Charlie mentioned the CCOs and the incentive money that we get for meeting the measures, the different incentive measures that they issue every year. I guess the measures don't really change. EO, CCO, we met all of our, enough incentive measures that all of the different counties that are part of that CCO got X amount of dollars based on how many Medicaid patients we have. So Lake County was guaranteed just shy of $33,000 to spend toward meeting the measures again this year. The CHIP program in December chose 3 incentive measures that they wanted to focus on. They wanted to focus on developmental screenings for children 0 to 36 months old, effective contraceptive use for women between the ages of 18 and 50, and lowering the rate of uncontrolled diabetes. And somehow, we had to package all of these totally unrelated things into one cohesive package. So we created, Beth Hadley from Public Health had suggested at one point that it would be neat if the county could have kind of a Live Strong campaign, something, a Be Healthy Lake County. The idea being bigger than Lake Health District, bigger than Public Health, bigger than any of our one entities, something that we all could buy into to promote health and well-being of everyone in Lake County. And so we landed on Outback Strong, tying into the Oregon Outback campaign that's been going on for however many years. And then strong just seemed like a better word than healthy, because we're Lake County and we're independent, we don't want to be told to be healthy. But strong is a good, positive word. So what you guys have is just kind of how we pitched it to the CHIP program, to all the different members in there, how we might be able to promote this little girl and the little baby who I love. For the developmental screenings, this woman, this normal-sized woman, to promote effective contraceptive use, and then the cowboy, of course, because it's Lake County. Just an idea of what this campaign might look like. So for the developmental screenings, in addition to, we're hoping to have flyers, have posters, have t-shirts, what have you, to promote this campaign. But we also have specific incentives. So Lake Health Clinic and Public Health right now does a lot of these developmental screenings, but EOCCO says that, it's Medicaid in general says that you have to have an actual doctor or a nurse practitioner, is that right? Or a physician assistant has to sign off on these, and they don't have any of that available at Public Health. So we were running into the issue of these parents bringing in their kids to get screened, and then no provider actually signing off on those. And for Medicaid and for reimbursement, that's what counts, is the provider signing off on it. So we are gonna be offering diaper incentives if they get their screenings done at Public Health. Public Health will send them over to the clinic to get everything checked out by a doctor, and then they'll leave with a package of diapers, whatever the appropriate size is. Because this money is for all of Lake County, we are also, Warner Mountain Medical is going to be a part of that. They prefer to do all of their screenings in-house, but they're going to be able to offer diapers to Medicaid patients as well. And Lapine Community Health Center operates the clinic in Christmas Valley, and they already have a diaper/gas card incentive program, so we'll be reimbursing them for that as well. For the contraceptive use, the clinics reported that a lot of their medical assistants are not very comfortable asking women about contraception. So part of the dollars there that we asked for it's gonna go toward training and making sure that these MAs understand why they need to have these conversations and how they can have these conversations. And then for diabetes was kind of a tricky one. For most of the measures, we know exactly where we stand in Lake County and how far off the mark, how far off the goal that EOCCO has set we are. No such measurement exists for this uncontrolled diabetes measure. And so part of the money, we're gonna try to figure out what that baseline is. I have the numbers from Lapine, so we have we have the Christmas Valley Clinic taken care of, but the money will help Dela with Warner Mountain and Juanita at Lake Health pull those numbers, actually take the time to go into patient charts and figure out how many people with uncontrolled diabetes we have, so we have a baseline number to work from, which is gonna help us in future grants. We have an opportunity to partner with Sky Lakes through a totally different grant that Klamath has received that's going to allow us to offer Living Well classes. Living Well is this whole program created by Stanford. It's a nationally recognized, research-based program. They have a couple of different tracks. There's a Living Well with Diabetes class that ties into this, a Living Well with Chronic Conditions, and Living Well with Chronic Pain is a new one. But we're gonna be able to offer these classes here. So we're gonna offer incentives. We've tried to hold these classes in Lakeview before, and they tend to start strong and then kind of fizzle out. And Stanford says you have to have X number of people attend consistently. So we're gonna offer incentives to encourage people to go to these classes. We're gonna offer support groups afterward that will cover things like healthy cooking and going to, there's the Strong People program at the senior center. There's a walking club through the extension service. There are all these recreation activities out there. So we'll kind of give these diabetes patients and their families more tools to help them control their disease. So that's the hope with that money. That's the money that we were guaranteed through EOCCO, and we just have to hope that they approved our plan. And then they also had some competitive programs that we could try to opt into. So there was one related to colorectal cancer that a third-party vendor will actually mail out the tests, the FIT tests, and I can never remember what FIT stands for, but the test that you submit back to the clinic, the fecal test, fecal something, anyway. So this third-party vendor will handle all the mailing. They will make calls on behalf of the clinic. It's going to be both Warner Mountain and Lake Health Clinic. Well, basically all we'll have to do is ensure that once these tests come back that we follow up with patients, we schedule people with follow-ups who need follow-ups, and if we get that one, it'll be valuable and we hope improve the colorectal cancer rate in Lake County, but also take a little bit of stress off the clinic because they're overloaded, and this is one step that they won't have to do.
So does that get mailed to everybody, a certain age?
We're not sure. We asked that question, and that's we don't get to choose who. It's EOCCO has the list of who is on, and I'm assuming that it probably is a certain age group. Probably, yeah.
Probably over 50.
But they didn't have any firm numbers for us to work with, but yeah.
At the next meeting, just so that you know.
Yeah.
Our vendor, our chip coordinator, will be here to talk a little bit more about some of these programs that we're working on. That, I hope what you hear is that what Christy, what our vendor, and of course Francine from the Wellness Center are working on is how to integrate all of the providers of health services in our community, whether it's through the hospital, through Water Mountain, through the Pine, through public health. We really have a lot of people working together to improve the health of our community. And it's exciting to be a part of it. Christy continues to help us look for the money and find the grants, and each component of that is involved. I think it's really exciting that they're working so well together.
So,
Impressive. Yes. Thank you, Christy.
oh, I'm still going.
Oh, you're still.
I'm still going. We had another opt-in from EOCCO. Baker County put on this legendary health fair. They got all the providers in town to agree we will not do the basic sports physicals this year. We want instead to offer a more complete wellness check for these teenagers. So in addition to the physicals that they need to play sports, they're getting a depression screening, they're getting drug and alcohol counseling, they're getting their immunization records checked, they're getting talked to about nutrition, they're getting talked to about all of these broader things, and the providers get accounted as meeting an incentive measure. So we're gonna try to do the same thing here. That one came together kind of at the last minute. We've all been really excited about it. The details are still kind of in the works. We got Bobby on board. Bobby was the linchpin. You all know Bobby's the linchpin. She's been running these sports physicals forever. So we got Bobby on board. That was the key, and we're figuring out kind of what it is gonna look like, but all of those components I just mentioned are gonna be part of this health fair. We built incentives into the budget. All the kids who go through, we're gonna set it up like Baker did. They gave every kid a passport to health, and they got stamps on their passport as they visited each station. And then if they turned in a completed passport, they got a movie pass, which doesn't work in Lakeview. So they're all gonna get a pool pass, and they will be entered to win a bike. So we're hoping that's gonna be enough incentive to get these kids to participate and to enjoy it. We're hoping we can have the blender bike. I don't know if you guys have seen this. Oregon State Extensions has these at some events where you pedal and you mix a smoothie, so there'll be something like that. There'll be an art project. If the budget's approved, then it should be a pretty fun event. And then the other piece, so those are the EOCCO.
When is that scheduled for?
May or June, depending on Bobby's track schedule.
But you're not gonna have any sports coming up in that.
That is when traditionally all the fall athletes get their stuff done. So this is kind of piggybacking on the normal schedule that they would be doing then. Yeah. And
Any ideas what percent of the student body that you'll be covering with this?
It's going to be offered to everyone in 5th through 12th grades because the rules just changed this year that now 5th and 6th graders have to have the physicals as well. So it'll probably have to span at least a couple of days. We'll need to get down to 80K. It'll be a more age appropriate, thinking especially of the reproductive type talks. It'll be more age appropriate for that level, but still have the same incentives for the kids to participate. We might knock out some of the Pop Warner kids too. You just never know. The other grant that we turned in is the one that Melinda mentioned. So Francie, our new prevention coordinator, has been working pretty hard to pull in even more community partners for what we're calling Outback Wild. There's this national curriculum called Project Wild that teaches kids. The goal is to get them more comfortable outdoors. In Lake County, our childhood obesity rate is just insane, and the number of hours that kids are spending on their cell phones and playing video games and just sitting is ridiculous when we live here. And they're not going, anyway, I won't rant, but this is a curriculum that's designed to get kids outside. We're hoping to train teachers and anybody, 4-H leaders, anybody who works with kids to be able to issue this curriculum to get kids more comfortable outside, get them engaged in the outdoors, and then we're expanding the curriculum. So in addition to just working with kids, we have a piece that's for Head Start, we have a piece for older kids. We want to be able to, we want kids to have something that's bigger than themselves, so that they see, I can do this thing that's making this change in our community, and that will maybe empower them to see that I can make healthy decisions that will help me improve my own life. So we are hoping to plant pollinator-friendly gardens in downtown Lakeview. We've been talking with Roberta, our new city manager, new returning city manager, talking with these guys, long-term care, assisted living, partnering kids with adults so that we're bringing the intergenerational piece together and having a beautification piece, a piece that's gonna help the bees because the bees are all dying. Just a broader, getting kids outside, working with older people, giving them a community project that's going to give themselves pride and we hope build up some pride in the community in general. That's it.
That is it?
That's it.
Thank you, I am so
Nice
impressed.
presentation.
Thanks.
That's very nice. Exciting. All right, we'll move on. We have a compliance update from Patty.
I'm afraid to use the computer now.
You can just tap Cheryl on the shoulder and she'll hit the space bar.
Stand here?
Sure.
You want us to down?
Yeah, is it here?
I'll move.
Oh, here, I'll move. Well, the computer's right there. So
Oh,
you're
you're
the
fine.
computer.
Everybody's moving.
I don't know how to do it. She just
Hit the space bar. Yeah, space bar.
Okay, so it's been a year since I've been over here to talk with y'all about compliance and where we were. Gave you an update about a year ago on not regulatory, revenue compliance. Have a little bit more of an update today. The 3 focus areas, just to remind you, what I look at most often are regulatory revenue and the HIPAA security rule, which is really about electronic security and electronic compliance. The activity that I did with my committee through 2016 was really, for regulatory compliance, it's all about, are we abiding by what our rules and regulations are nationwide and statewide. So we created policies. When you create policies, I'm not going to show you, well, we did X number or whatever, but this is just a description, a verbal description of what we did. Most of the policies were created for acute. Long-term care is now showing up at the table, and they've got some policies, of course, that they're going to want to be creating also. And this is a good committee to run that through. We are discussing a number of things in that committee, including how policy should address our changing patient population. And we do have changes. We have challenges like different drugs that come in. We have a changing attitude in patient populations that didn't used to be out there. So do we need to address that with policy? We don't really know. That's something that we discuss in that meeting. We can't meet very often. When we meet, it's for 2 hours. There are about 4 of us that show up at the table, and we've only been able to meet 7 times in last year. Sometimes we can't meet if we've got a critical person gone, and that could be any of the 4 of us. If they're out, then kind of sets us back a little bit. So we meet as often as we can. We are dedicated to it, but we can't do it as often as we would like. We have opportunities, of course, for regulatory compliance, and it's, as I mentioned, is outside of the acute. There are OSHA issues that need to be addressed. There's FEMA, there's Office of Civil Rights, which takes care of the HIPAA issues. That we are getting, for a long time in Lake County, we thought, and we were kind of hidden from the eyes of the world, and that's just not so anymore. So when we have a complaint or if we have an issue that we have to deal with, we hear from one of those agencies, and we have to respond appropriately. So far we have. To remind you about the Revenue Compliance Committee, in 2015 we had a goal, we had a dream, and it was to improve the ER date of service denials that we were getting. It was pretty easy to see that there was an issue there. And you pick out all the reasons for a denial that we may get, why we might not get paid as soon as we want to be paid, or as soon as a patient might want to get their bill for. And it was pretty easy to pick out that the date of service was the #1 denial reason in the ER.
What does that mean?
That means that for some reason they came into the ER and they either didn't have coverage, maybe they were a Medicaid patient and they were eligible, but they didn't have coverage, or we didn't get the insurance information at the time. And remember, if somebody comes into the ER, we have an obligation to determine if they are in a state of emergency, essentially. So you do the medical screening exam and you make that determination. You don't even ask about insurance until that's done, or it's not technically in violation of EMTALA, but it is highly discouraged by our surveyors and by our risk management consultants. They don't even go there. It's just such a sticky wicket. So we don't, and it makes it difficult to always obtain insurance information. Another issue, and I won't go into great detail, but there are so many things that come up. One is, we have denials going on right now because our computer networks aren't exactly talking to each other. So the protocol, we need to be able to put in exactly their name, whether it's in radiology or whether it's in the clinic. So does that mean the full middle name? It gets ridiculous, really. But all those things are things to work through. So date of service denials we thought was going to be low-hanging fruit. It wasn't. There's never low-hanging fruit, it seems like. So what we have done is spent much of 2016 getting data right. What we were finding is in 2015, up to 2015, we had data that was kind of going into a bucket, or denials that were going into a bucket. And they weren't really being apportioned correctly. So when we tried to find out, really hone down and find out why somebody was denied, we didn't have great data. So what was happening is people would have to pull it out of the bucket, send it back through the insurance company, and it would take time. When I say, by the way, date of service denials, doesn't mean we never get that money. Normally what that means is it just takes a lot longer to get it, and when you have longer days in AR and you've got some uncertainty about where the patient might be, if they came in from another location, maybe they're out of reach now. So sometimes we didn't get the money, but more often than not, it just took us longer to collect on it.
So are you classifying just bills that you did bill incompletely? If you know what I mean? They got billed, but it wasn't correct.
Right.
Okay.
So we think that, and I was talking to Charlie about this before the meeting, so I'm freaked out, but we have a lot more now. I mean, the number went way up in denial of date of service denials because we're putting it in the right place now. It's not spread across the board. So that is something that now we can grab that number and now we can work with that. So that's what we did in 2016. The next easy hit was medical necessity denials that came into the ER. And that actually just triggered us to turn on the module in CPSI that kind of looks at those and can tell us right away if that's a medical necessity, a correct code, for instance. The other focus area is the HIPAA security rule, we call it, and you guys have heard an awful lot, I know, about cybersecurity and electronic protection of our medical records. We have it on two fronts. We have patient information that has to be kept private and secure, and we have billing information also. So there are two sets of regulatory issues out there that we have to pay attention to. So Stephen has been hard at work helping us with that committee. There have been policies that we had put into place during that committee and that really helped us quite a lot. When the OCR comes knocking to say, did you have a breach in this area? And we've been able to say so far, no, we really didn't. Or that we had all the protections in place that we're supposed to. It's all right, it was kind of a nice little interruption. So the next big area that we have in compliance, of course, is all about policies and procedures. That's kind of what my life is. So, of course, they have to be easily available for staff, and they have to comply with whatever the regulation And we have gone to an electronic format. Electronic format's greatly helpful in driving us to update our policies appropriately and on time, and to make it available for all staff. And I'm going to show you that. Well, one thing that we were told when we were going to the EHR is an EHR won't correct the problems that you already have. And that's kind of what has happened with our electronic portal for our policies. So we're having some issues getting them uploaded. A lot of the policies are in paper format. They are outdated, some of them. It takes time and it takes manager attention. It's not something that you can just farm out to somebody who might be on light duty. It takes management attention. So we've been trying to get them uploaded. We've been working on it, just plugging away. Acute, you can see, has the most number of policies uploaded, and that's probably only half of their policies. And they're working very hard at it. Dietary has all of their policies. They don't have very many. Radiology has all their policies yet. But you see a lot of departments that don't have any submitted yet. So we have a person who is part-time here that's kind of trying to go around and help the departments find out what they need so that we can get them in here. This would go a long ways towards helping us in compliance. Other areas for compliance attention really are, you know, it's kind of the usual hit list. So the rural health clinics, of course. Compliance now requires auditing and monitoring. That's one of the elements in compliance, in a compliance program. And what they're requiring now is that you make it meaningful, and that means you're auditing and monitoring it, which is very difficult for us to do with the resources that we've had dedicated to it. I'll just be upfront with that. So we also have compliance for the hospital. 2017, we have new COPs, or conditions of participation, that come out from Medicare. And those are a few of the things that came out for them this year. A garden, so for long-term care, they have new COPs that are really around training. So their COPs are focused on that. Home health and hospice continues to be an area that needs to have some outside. It's not to say that these areas aren't being monitored, it's just that they're not being monitored by a somewhat, it's not someone outside their own department monitoring or auditing. And you know that that's kind of important to do. So brand new areas that we haven't even addressed yet are going to be assisted living, the DME, and behavioral health. And you know that Charlie's always got something up his sleeve for next. And you can laugh, but it's terrifying sometimes. I have to try to address some of those. Oh, I guess I do have one last slide. So in 2017, I would really like to focus on improving the revenue cycle. I told you that we had those denial of service issues. We have to do more in our regulatory compliance, more policies and procedures. And a big issue is the auditing, monitoring, and corrective action plans. Yeah. Any questions about this? No numbers for you today, but that's good, right?
It sounds like a whole lot of work for
It could be. I spend a lot of time in risk management. But that is really an explosion in healthcare.
I'm just waiting to see what will happen when the bomb care gets replaced.
I think that we still, I mean,
If it
even
gets
if,
replaced and not
even if
just
he
rebuilt.
takes half, what's he saying, if he takes for every new regulation tour gonna go away, there's still a lot to pay attention to.
Well, thank you, Patty.
Thank you.
You want to share that? I can.
Medical staffing, and Dr. Gallagher.
Dr. Gallagher was not able to be here today, but we do have, I believe we mailed out to you the recommended
Yeah.
compliance.
I'll go ahead and just ask for a motion.
So moved.
I- Question,
Wait.
You got a question?
question,
Okay.
not so I would mention it.
Yeah.
Who's Dr. Proudy?
J.P. Proudy is a third-year resident at Cascades East in Klamath Falls. And he has made himself available to come over at least once. We've tried to arrange for him. You know, one of the things that we always try to do is get some of the residents, once they, in their process, their 3-year process, first year they don't all have unconditional licenses. They are licensed physicians, but they still have some restrictions. In the second year, they can get an unrestricted license, which allows them to, what's used to be called moonlight, and work in other hospitals or emergency rooms. Dr. Proudy is one of those that has met that criterion. So we try to get them here, get them a little idea of what it's like to work in a remote frontier hospital, and helps them with a little bit of extra cash.
These all have been approved by, yeah, so I'm also moved to be presented.
I'll second that.
Those in favor?
Aye.
Aye. Thank you.
We also have a change in the bylaws that we sent out to you. And that we need to have the medical staff, or the board approve change to the medical staff bylaws. What this does is allows the district to do background checks on all physicians. It's required that we do background checks on all employed physicians and all employees that have access to patient care. This allows us to do that for all physicians.
There were two different
TB
provisions,
testing.
right,
And
that
TB.
they were addressing? Yeah, the other
There's
was
also-
right.
Yeah,
TB.
Also the
Yeah,
TB
okay.
test.
Are these new additions, Charlie, or are these revised?
The highlighted are the new, the
They're both
revised, what we've added. Before they had to do the TV portion of it, but we've just basically revised the wording so that if they're in patient care, they have, these are the requirements that they have to.
Now, this is just physicians that are physically here.
Providers, so that can
Yes.
include nurse practitioners.
Okay.
And that would be anyone that has, that provides care within our Lake Health District. So it could be in a clinic, it could be
But these
in the hospital.
these remote radiology people.
No.
You know what I like to see in these when we do this sort of thing? I like to see the old wording and the
Struck
new
out,
wording.
yeah.
Yeah,
Okay.
so that there's, so you line out what's being deleted and then we know that it's a revision rather than a new.
Would you like to have that before we approve this?
No,
We can do
I'm
that.
fine with that.
Okay.
But I just would prefer that in the future if we can.
I can do that.
Good suggestion, thank you. Did you vote for that?
No, they
Motion
haven't.
to approve it?
I'll move that we approve the medical staff bylaws amendment as presented.
Second. Moved and seconded, those in favor? Aye. Aye. Thank you. Pass. Employee recognition.
Before we do that, we do want to do the critical access
Oh,
hospital.
good, okay.
You keep skipping ahead there, Chuck. That's
Trying to get out of here. Sorry. Go ahead.
We need to have annually, critical access hospital, one of the conditions of participation, like Patty talked about, that's those COPs, conditions of participation. We have to have a meeting of the critical access hospital committee to look at what we're doing and involve people from outside of the organization. Here's some of the things that we're doing, and have, address any concerns that the community might have. Our recommended number, our individuals to serve on this committee would be somebody from administration, which would be me, someone from either the director of nurses, Teresa Squires, or her designee, medical staff member, Dr. Gallagher is the chief of staff, or his designee, staff nurse, we're recommending Maddie Bunton, a mid-level practitioner, Lisa Cahill has in the past, been happy to provide that service. That would be a great, she continues to be interested in doing that. Community members, Jake Greer, Mary Anderson, and Beth Hadley from Public Health. Jake from probation, Mary Anderson, a very active nurse in our community, and who has often been coming to our meetings in the past. And last, we would ask that our Patty Newton and Namrata Dave from both quality and compliance come and make discussions and presentations, similar to kind of to a little bit of more, maybe more abbreviated or more focused, depending on what they'd like to talk about that to this group. Those are the people that we would recommend that be on that committee, and it needs to be appointed by the board.
These are the recommendations that you want us to follow through with, or do you contact them to see if they are willing to serve?
Both. So if you appoint that, so what we're saying is it has to be community members. We've come up with some suggestions. They have indicated a willingness to serve, and so we've already asked them.
Okay.
And if you know of other people, we're happy to know them, but we need to have certain categories. Medical staff, staff nursing, mid-level, and community members, quality.
And that comes from the policy, the critical access hospital policy,
Have
committee
we
review
approved this in
policy.
the past?
Yes, you have, every year.
And so this is kind of a reappointment?
Yeah.
And we had to remove a couple of people and add some other names, because previously Ben Paz was part of it, but now Trace is a member of the district, so that's added.
Does that wording of the policy say the hospital board approves it or the board chair?
The
I was thinking the board chair appointed.
board chair appointed.
It's an appointment, and if you do that, if you want to just appoint this, we don't need to have a board approval.
I think that's the way it's worded in your policy.
If that's the case, then, if that's all right, we'll just go ahead with that.
Thank you, so number one.
We'll take care of it.
Great. Just want to make sure. And we're planning on having the meeting within the month. Try
You
and
mean
get that.
just annually?
Yes. That's one of the conditions of participation that we have those meetings.
Now, we have some employee recognition.
Every month, it is just always just fun to think about who makes such a difference, especially in a given month. The person we'd like to honor today is an individual who is diligent in finding solutions to problems without seeking to place the blame, tenaciously attacks problems, doesn't let them fall away from being resolved. This individual has taken on additional duties and responsibilities. We need to have, and we've made some pretty darn good progress in our billing through in our clinic, and it's getting better and better. This individual has done a great job working with managers and peers, and always has a very positive attitude. And it is Carrie Cornelius.
Nice.
She's really done a great job. But also, she effectively is one person doing the job of two people. So she really has done a great job.
Very good, thank you.
Thank you, Sheriff.
If you could just get all your employees to do the job of two, then you'd be in good shape.
I hear what you're saying.
CEO report.
You know, it's kind of, feel badly for you, you've been coming, it seems like every week I see you here. It's been kind of a busy time, and so I'll try to be quick. As Larry said, we have the senior class, 10 students, will be starting at the end of the month, and we're very hopeful.
They're starting tomorrow.
Okay, they're starting tomorrow, and we'll be finished in 6 to 7 weeks.
Are some, excuse me, are some of those gonna be, what's the word I'm trying to say?
Employees?
Subsidized?
Well, we have our orientation tomorrow morning, and then we have our committee is set for 1 o'clock tomorrow to interview for scholarship.
Aren't you sitting on
And
that?
is that,
And Judy's
yes, is that part of the 10? Are the, some of these?
8.
8 of them are
Mhm.
part of the 10. Where are we meeting tomorrow?
Cafeteria annex.
Annex, right next to cafeteria. But what we did, because we usually only have 8, we're only allowed 8 students per class, is we're actually, I have a full-time instructor now, so we're running 2 courses in conjunction. So we're just staggering their lab days, their clinical days, so we have Class A and Class B. So we did 10 interviews Monday.
So do you feel that the helping to pay their costs is stimulating your numbers?
And I was really impressed at the applicants this time, the professionalism, they all did great interviews Monday. The caliber of people we're getting was really impressive, so
Excellent.
I'm hoping that they turn out to be good employees. I've already picked which ones will be good in long-term and which ones will be a good acute care CNA.
Only they listen.
Huh?
Only they listen.
But,
Okay.
anyway.
Thank you.
There are lots of things going on. No doubt. One of the things that's happening, on Monday, we will be, as part of our CPSI software and hardware, we are constantly having CPSI software updates. In fact, I think we've had 2 or 3 just this month that are routinely being done. It's been now 6 years since we got our CPSI system, and it's time to upgrade the hardware. So on Monday, a team is coming in to, and we've been running a second set of servers to run parallel with our current. One of the things that's happened is the backup tapes that we do on every day. So when we talk about redundancies, we have a backup tape done every day of our clinical data. Then we have a backup tape that's done weekly. Then we have one that is done monthly, and that monthly is sent to Alabama for insurance. And that one is actually sent to Atlanta in case there's a hurricane that hits Mobile, Alabama. What that does is it ensures that at CPSI, should our server go down, they could fly out a server that has at least no later than 1 month's worth of data. So if we had a fire and our servers were destroyed, we would be able to retrieve all of our data at least 1 month. That's old. So now we do it daily and weekly, and they're stored offsite. So we're replacing all the servers, and in that process, updating. Backup tapes have outdated, and they don't even make them anymore. So we're getting the maximum use of our equipment that we can. Omnicell, which is the software that we use in our medication room for when the nurses access any of the drugs. We just had an update on that this past week. So it's vital that we stay current in all of our software. Our clinic, we just attested for patient-centered primary care home, the PCPCH status. If you recall, that helps us get an additional payment from the CCO and some of the insurance companies. We reached level 4. There's out of the 5 possible levels, and we believe we will qualify for level 5. But when we do, then they'll come up for a true in-fact inspection. Up to that, they don't have to inspect every year. But we still bring in experts to help us ensure that we are delivering the kind of care that we need. One of the key reasons that we're able to reach that is the integration with mental health. And so we do this, and we work with Warner Mountain Clinic because they too are striving to be a patient-centered primary care home. And we have an after-hours call capability. So if someone calls the clinic and they actually get an answering machine, they get a nurse that answers the call. So that's important. Just like we have for mental health, we have call service after-hours support. One of the things we talked about as our, not quite JPA of Oregon, but our relationship with the hospitals in Burns, John Day, and in Heppner. We got a grant, about $80,000 from the Office of Rural Health this past summer, and we did some lean training. We did a fair amount of lean training this month, and it specifically involved our frontline staff in the clinic. You recall the key thing that we were looking and Nam and Juanita and many of the staff members are working on, is how do we have better communications between clinics and the hospital. So they're working on that. And it's really exciting to see the progress that they're making. Cheryl and Diana Trechter and filed for our meaningful use. As you recall, one of the reasons we got the dollars from the federal government to help pay for our electronic medical record system is that we had to meet the criteria for meaningful use. And since 2011, we've been filing for that. We filed, and it appears that that will have gone through. We are meeting the requirements of doing it. So not only do we buy the system, we're using it to the degree that it is expected. In fact, we exceeded what the minimum requirements were. They get more difficult every year, but our team is working on it. It's getting easier and easier as we help our physicians and our nurses to use the system. It's not perfect, I don't want to ever tell you that, but it is making progress. The orthopedic program, we are meeting weekly with, in this room, with just about everybody that is touched by the orthopedic process. And it's really an exciting process to watch as everyone identifies problems and then finds solutions for them. We've been looking at equipment, but we're also looking at training. Yesterday, Amron, for example, said, I had no idea we would get so much more referrals, and we haven't even started doing the surgeries yet, just in all of the other services. He's thinking that within several months we may need to add another physical therapist because we're that busy. And you've seen the numbers of what's happening, and that's on top. So this is on top of that. We will be sending the week of the February 15, 16, entire operating room crew to Portland. They're being hosted by one of the vendors, and they're going to practice on a cadaver to do joint replacements. So the team, the process of taking care of, this is how we do things, the steps, all of those things are done, and so it's done properly, done efficiently.
How many on the team, Charlie?
In the operating crew, I believe there is, well, it's not just the surgeon, but the assist and the scrub techs, and then the other people that know how, when they're, the techs that are cleaning the equipment, knowing exactly the steps and the processes, so that everything moves as best as it can.
We'll see her days go.
Oh, yes. Oh, yes.
Can we have them all out of the hospital at one time?
So what we're doing is we've made arrangements to have, we will have 2 techs available to assist should we have a cesarean section or an emergency. One is actually coming in from Harney District Hospital to be available to deal with that problem. And we will have a backup CRNA just in case we have to deliver a baby. So that's, again, when we talk about the kinds of issues that everyone is involved with when you get 20 people talking about, don't forget about this, or what about that, making sure the software matches, and making sure that we know the billing process is set correctly. But it's marvelous to be a part of. So it's exciting. The swing bed program that I talked about, that the Office of the legislature put up $10 million, if you recall. Last year we talked about this. 4 programs. One is for rural rotations for primary care for physicians in their residencies. One is for population health. Another is for after-hours virtual clinics. And then the 4th, the biggest part, is expanding the swing bed program that we have. Carly Allens is the nurse that will be our coordinator that works with this. There are 15 hospitals that have indicated an interest in Oregon. This is only for Oregon. It's a 3-year program that's partnering with Mayo Clinic. And so we've started, kicked off on the process, and so our responsibility is to have roughly 10 hours a week of free time to learn about how this process works. So it's pretty exciting. In the Wellness Center, we have added Heidi Martinez. I think I told you about that at the last meeting. She started January 9th. She is our clinical supervisor. There may have been some confusion. Trace Wanzer continues to be our executive director of the unit, and she's responsible for the clinic. Clinical supervisor is the one that makes sure that our therapists are delivering the best care, that their records are, and their use of our electronic medical record system, which is called Credible, is used properly, our charting is done correctly, all those components will do. We interviewed a CADC, so that is a person that is there are different levels of training for dealing with substance abuse disorders. So we have someone in Christmas Valley who provide that service, and we're going to have more people delivering that service here. So we're interviewing for that. Hopefully that we'll find people that can do that. The CCO, our vendor will be here next week, but
You have one more that's going into wellness, the QMHA to Carrie Trail.
okay.
His manager.
Yeah, you're right, I signed that this afternoon. So one of the staff members that was in our clinic, who has the qualifications to be a qualified mental health associate, I forget what the A is, but associate. They have to have had a bachelor's degree in a health science, in a social work or social sciences, and some amount of training to be able to be in that role. So again, that is going to support our therapists. One of the big problems that often happens in the world of mental health is the ability to manage all of their non-clinical issues. They become social services issues. And so in order to make sure that they get the care that they're needing, they need to be able to help sure that they show up and that they have their other life choices made well. So that's part of our process. So, our vendor will be here next month to talk about some of the changes that we're doing as part of the CCO, as Christy said. I think I told you, if not, I was at the CCO board meeting on Monday, and the predictions are that when we think about what impact it will have on us, changes that the new administration are planning, most people believe that there will not be a unilateral abolishment of the Affordable Care Act. And from our standpoint, any changes would probably not happen until 2018. So it would not be happening. It'll take time for these transitions to occur. So our CCO continues to be, in the words of many, is to be one of the better CCOs, more egalitarian, and it's pretty good. And I think that's good for our community.
Are they affected by ordinance budget problems?
Absolutely, absolutely. But again, those changes that our legislature is going to deal with, they will probably not be immediately impacted. It will be a little bit more measured process. And you have to keep in mind that because we are a frontier critical access hospital, we will continue to be reasonably protected because of our cost-based reimbursement. So again, that's reasonably protected. The response on the geothermal letter that was submitted to the town, we have not yet had a full response from the town. We're working with Daryl Anderson to get a response on that. When it comes to the clinic remodeling, we are a little bit delayed from our March start date, largely because the issue of how we handle our heating and air conditioning. If you recall, we started out the discussion with, do we have it all geothermal? Do we have a replacement of the existing systems? I got today, and I'd be happy to show you if you want to see all the fine detail that Daryl provided. Would you like to see this? Anybody care? What it says is what Daryl's estimate and use with it's a company called ArcSign that is working on the HVAC systems. They're recommending that it be a combined system with the geothermal. So what they're asking is, the difference in cost is hard to determine from this analysis. But bottom line is that Daryl recommends that we go with the combined geothermal heat and a chilled water system. And that is important because the architects have to design that before they can put it out to bid. So I'm recommending that we
But he didn't give you a fixed difference number?
What he estimated is the life cost, frankly, I don't understand. I could read it to you, but I don't quite understand. What they're telling me is they recommend that we go with that design. I'll try to get a better answer from Derek.
So you really don't know what the increase in cost is? We had this discussion.
The question got to be, do we go with the conventional HVAC system, not use geothermal heat? And if we put in a chilled water system, whether it's connected to the hospital or separate and built in the sort of the second story of the center piece. And what the recommendation is to go with the combined system. I can't tell you what the exact cost is going to be because these are estimates based on the amount of energy that we've used from the existing facilities and the new based on square footage. Wish I could tell you exactly.
Charlie, what was it we decided was too expensive to do? Go all straight geothermal?
Yes.
So now we're going to go.
It's a hybrid, it's a combination.
Partial.
So you're basically not talking about Ford, you're talking about a device that uses the geothermal. Is that right?
I believe that's correct.
I think that's what you're saying.
I believe that's correct. So, I'm not gonna, it's hard for me to give you more details.
Has ZCS, I mean, is he?
ZCS took this information because Daryl was pretty adamant, worked with the ArcSign engineers and showed them, and they looked at comparable costs and predictions of costs, came up with, and they agree that that is the better system. It's hard for me to tell you otherwise.
Sounds reasonable. I don't think you need a motion on that.
No, we don't.
We can discuss it further in executive session or any.
We can't.
Are you saying it'll come back to us at some point, though?
No, in executive session tonight, if we have a question, we want to
Okay.
talk further, we can.
For all intents and purposes, if the design comes back and the contractor, Detroit, says it's going to cost this much more based on that design, we go back and ask them to redesign. That's really how we're trying to deal with this. One of the cost questions that we got a response, we're not finalized on yet, we're still working through. I mean, this is still a moving target, so I don't want to bore you with all the details. But if you recall, we talked about relocating the transformer out by the walkway between the hospital and clinics. And the estimate that Daryl came up with is it appears that the cost to move the transformer is about $15,000 for Pacific Power. But when you add in the other costs related to that, because you have to, when they disconnect it, you have to have power. You can't do it, you can't just turn off the power to the clinics. It's about $38,000 to move. What they're recommending is that we do that outside of the project, so that it is not included in the overall increased costs that occur when it's a big project like this. We have it separate. Talked with the Pacific Power estimator, and they still don't have a firm number on that 15,000. They're still trying to come up with final estimates, and that was as of yesterday morning. But as soon as I have that information, I'll bring it to you. That's kind of where we're at. The auditors believe that they will have a presentation to you that was scheduled for the 15th of February. That's a Friday. 17th of Friday. 17th of February, which is a Friday. And we're shooting for 12:30. As of a couple of hours ago, they were almost finished. Do you have any questions?
We have to come back for some executive session work, if anything else in general session. If not, take 10 minute recess and return at